Hello everyone, welcome to JRM Pediatrics. We are starting a videos of the new series called Metabolic Disorder series, and the first video in this series is Approach to Hypoglycemia in Infants and Children. So in this video, we are basically going to learn an approach. Not exactly everything from the Nelson I have included, but yes, I have included important tables, and I have also made a table so that it is easier for us to approach cases in a real life scenario or for MCQs as well. So to begin with, first, hypoglycemia is that range of low plasma glucose concentration at which the signs and symptoms of brain dysfunction develops. So hypoglycemia in infants and children doesn't really have an exact value that below this it is called as hypoglycemia. It is basically a range in which the symptoms develop, and it can be defined as hypoglycemia. So our target for treatment is anything more than 70, as you can see here. Between 50 to 70 we have neurogenic responses or the autonomic nervous system responses due to release of epinephrine and glucagon. Now this neurogenic responses include anxiety, perspiration, tremors, pallor, tachycardia, perspiration, pallor, tachycardia. Now after neurogenic responses, the range is 50 to 70. After that, below 50 we have neuroglycopenic responses. So this includes headache, mental confusion, visual disturbances, inability to concentrate, amnesia, refusal to feed, seizures, coma. So refusal to feed, seizures, coma, headache, inability to concentrate. So below 50 is the danger zone. So we have to avoid going below 50, and if it goes below 50, it is the target to terminate any provocative tests that we are doing. Next, coming to the diagnosis. This is purely what is written in the Nelson 22nd edition. So as per the Pediatric Endocrine Society, hypoglycemia disorder should be evaluated in case of older children presenting with Whipple's triad. Now what is Whipple's triad? It's nothing. It's just a triad that says that there are signs and symptoms consistent with hypoglycemia. Consistent with hypoglycemia. There is low plasma glucose concentration, and there is resolution of the signs and symptoms on correction of the plasma glucose. Resolution of signs and symptoms on correction of the plasma glucose. Now other conditions are younger children or infants with plasma glucose less than 60 milligram per deciliter. Neonates at risk of persistent hypoglycemia. We should screen neonates with LGA, IDM, preterm associated with history of perinatal stress, family history of hypoglycemia, congenital syndrome with hypoglycemia. Apart from this, we also have to rule out persistent hypoglycemia disorder if a child presents with severe hypoglycemia and is unable to maintain plasma glucose more than 50 milligram per deciliter up to 48 hours and more than 60 milligram per deciliter beyond 48 hours of life. Now this is a table from the Nelson 22nd edition showing the approach of hypoglycemia. As you can see, first for hypoglycemia, if the glucose is less than 50 milligram per deciliter, then we go for maternal and infant history and physical examination. Then we obtain the critical sample, and then we see whether there is acidosis or no acidosis. Further, each acidosis and no acidosis has different stems explaining what can be the differential diagnosis. Now, I have tried to simplify this table in the next part with a handwritten format, so it is easier for us to understand. Now, let us try to simplify the Nelson table. I have written this in a handwritten format, and I have also taken up some idea from the UK guidelines because the table was really good. So, I have tried to combine them both in a handwritten format so that we can easily approach patients as well as solve our MCQs. Now here, as we can see, hypoglycemia less than 50 milligram per deciliter. The next thing that we go for is the critical sample before correction. What does the critical sample include? It is serum glucose, insulin, C-peptide, growth hormone, cortisol, free fatty acids, beta-hydroxybutyrate and urinary ketones. Now the first step that we have to see is whether the urinary ketones or the blood ketones are present or not. After that, we will approach this scenario in two situations, whether urinary ketones are present or absent. First scenario is if the ketone bodies are absent, that is no ketosis or acidosis. Then we go for non-glucose reducing substances. If non-glucose reducing substances are present, then the scenarios can be either galactosemia or hereditary fructose intolerance. Now, if the non-glucose reducing substances are absent, then the next investigation that we do is insulin. Now, insulin can be either detectable or not detectable. If insulin is detectable, then the next investigation that we go for is C-peptide. If C-peptide is low, then we have exogenous insulin as the cause. If C-peptide is high, then the cause is congenital hyperinsulinism or IDM, insulinoma or transient neonatal hypoglycemia. Now, if the insulin is non-detectable, then we go for free fatty acid, and if the free fatty acid is present, then the cause is fatty acid oxidation defect. Now, the next scenario is if the ketone bodies are present and acidosis is present, then the next investigation we go for is growth hormone and cortisol level. Now, if we go for growth hormone and cortisol level, if the levels are normal, then we see if hepatomegaly is present or not. If hepatomegaly is present, then the differential is most likely glycogen storage disorder. If hepatomegaly is absent, then the cause is ketotic hypoglycemia or a normal fasting child. Now, if the growth hormone and cortisol level are decreased, then we go for ACTH level. Now, if the ACTH level is normal, then the cause is growth hormone deficiency. If the ACTH level is high, then the cause is adrenal insufficiency. That is it for this video. Thank you so much for watching. Hopefully I was able to simplify a few stuff about hypoglycemia. Please like, share and subscribe. Thank you and have a good day.